The hematologic system is essential to many functions in the human body. It is comprised of the circulating aspect of the blood products, the erythrocytes, or red blood cells, the white blood cells, and the platelets. White blood cells are involved in immune protection of the body. The platelets are the first responders when there is damage to the inner lining of the blood vessel. And of course, the erythrocytes deliver oxygen to the cells. We'll be covering the Unit 8A, Threats to Oxygenation, under anemia today. So let's get started. So, red blood cells, erythrocytes. They make up the largest portion of the blood cells. Mature red blood cells have no nucleus. They have a biconcave disc shape and a flexible membrane that allows the red blood cells to change their shape without breaking, so that they can pass through the narrow, winding capillary pathways. Depending on your age, gender, and general health, you probably have somewhere between 4.4 and 5.5 million red blood cells per milliliter of blood. Red blood cells are responsible for producing hemoglobin. A normal, mature red blood cell has thousands of hemoglobin molecules. Each hemoglobin molecule requires a molecule of iron. Only when the heme molecule is complete with the iron can it transport up to 4 molecules of oxygen. The globin portion of the hemoglobin molecules carries carbon dioxide to the lungs. Physiology of red blood cells. Now, the total number of red blood cells is carefully controlled through the process of erythropoiesis, which involves selective maturation of stem cells into mature erythrocytes. If there are too few red blood cells, the cells suffer hypoxia because there are not enough cells to carry oxygen. Too many red blood cells would thicken the blood and slow the flow. The trigger for control of erythropoiesis is tissue oxygenation. Now, that's the most important thing you need to remember for the physiology of red blood cells. The kidneys produce erythropoietin, which is a red blood cell growth factor, at the same rate as red blood cell destruction occurs, so that the circulating volume of red blood cells always remains constant. The growth factor stimulates the bone marrow to increase red blood cell production. When tissue oxygenation is less than normal, which is hypoxia, the kidney increases the production and release of erythropoietin. When tissue oxygenation is excessive, the kidney decreases the production of erythropoietin and fewer red blood cells are produced. Maturation of red blood cells requires the presence of certain vitamins and minerals. Vitamin B12 is often referred to as the maturation factor. A lack of B12 causes erythrocytes to become larger in size, oval, and somewhat irregular. These changed cells have a shorter lifespan. Folic acid is also required for red blood cell maturation. And without iron, of course, you cannot form hemoglobin. Now, anemia can be defined as a decrease in the total body erythrocyte volume, usually measured by a decrease in the hemoglobin protein a decreased hematocrit and or a decreased red blood cell count. Anemia is the result of either blood loss, impaired production of cells, excessive destruction of cells, or some combination of all of these factors. Anemia can result from dietary problems, genetic disorders, bone marrow disease, or excessive bleeding. GI bleeding is the most common reason for anemia in adults today. According to data from the National Center for Health Statistics, iron deficiency anemia, which is the most common form, causes 2 deaths for every 100,000 people. Those are just the deaths that we can identify. It is difficult to ascertain statistics with anemia because it is widely underdiagnosed. Patients often will not think they need to seek evaluation for fatigue and shortness of breath, which are your hallmark symptoms. They will pass them off as being out of shape or needing more sleep. The other reason we cannot tell how many people died from anemia is because it is not an actual disease. It is a clinical side effect that it comes from the result of some other pathologic disease process. Now let's begin with the classifications of anemia. Anemias can be classified under 2 basic headings: etiology, or how they happened, or morphology, which is the general appearance of the anemic cells. Etiology, blood loss is where the client loses a large number of erythrocytes and experiences a decreased oxygen in the blood as a result. The severity of symptoms is generally related to how rapidly the blood loss has occurred. If the loss is sudden, such as by trauma or surgery, symptoms will manifest almost immediately and be very dramatic. But the body is very good at adaptation and can often adjust very well to even a severe reduction of red blood cells, as long as the condition develops gradually, as with slow GI bleeding. Etiology will also be involved with decreased red blood cell production. Red blood cells production declines because the bone marrow is unable to produce them in sufficient numbers. This can be caused by suppression of bone marrow function, lack of erythropoietin, which is with patients with renal disease, or lack of vital components needed to produce the red blood cells, such as folic acid, iron, or vitamin B12. Another reason for etiology would be increased red blood cell destruction. Often, this occurs secondary to red blood cell abnormalities, such as sickle cell disease, but it can also be due to hypersplenism. That will cover most of our etiology, or at least the etiology classifications that are important in this lecture. Now for your morphology, again, remember that morphology is the general appearance of the cell. There are 3 classification groups in the morphology system. The first one is your normocytic, normochromic category. And remember that cystic refers to the size of the cell, and chromic refers to the amount of hemoglobin that the cell carries. So when we have a normocystic, normochromic category means that the red blood cells are normal in size, normocystic, and normal in the amount of hemoglobin, normochromic. Anemias from hemorrhage or chronic disease usually will come under this category. Microcystic hypochromic is your second category, and that means that your red blood cells are small, microcystic, and contain low amounts of hemoglobin, hypochromic. Iron deficiency anemia and anemias from renal failure usually will fall under this group. And your last category, your macrocystic, are red blood cells that are larger than normal, macrocystic, and these will usually be caused by liver disease or pernicious anemia. Now we do have degrees of anemia. So mild anemia may exist without any symptoms at all. If the client exerts themselves, then they may develop palpitations, dyspnea, and diaphoresis. Clients with moderate anemia experience symptoms when at rest as well as when they exert themselves. They have increased palpitations, dyspnea, and fatigue. And then patients with severe anemia, these have tissue hypoxia is more severe, and the symptoms become much more numerous as many body systems are now affected. The table 31.3 in your book on page 634 details for you the progression of the clinical manifestations of anemia. In this slide, we list the manifestations of generalized anemia. Clients' symptoms will vary greatly, with no symptoms at all to very mild symptoms to life-threatening manifestations. Regardless of the cause, every form of anemia reduces oxygen carrying capacity of the blood and produces generalized tissue hypoxia. The body's attempt to compensate for the resulting oxygen deficit is what leads to the manifestations that are commonly seen with anemia. Decreased erythrocyte volume results in anemic hypoxia, so a decreased oxygen availability to the tissues, specifically due to the decreased concentration of functional hemoglobin or reduced number of red blood cells. This differs from hypoxic hypoxia, which occurs due to the defective oxygenation in the lungs as a result of heart or lung defects. How severe symptoms become is dependent upon the degree of anemia and the presence of any coexisting diseases. But generally, the more quickly the anemia has developed, the more serious the condition of anemia will be. If the person has become anemic in a very slow fashion, the body will adapt and have few, if any, symptoms. But if the patient is experiencing severe anemia, the heart may have to pump harder and faster to make up for the decreased oxygen carrying capacity anemia causes. So if the person is active, they will show more pronounced symptoms, whereas an elderly person with decreased levels of mobility and very little exercise may have few or no symptoms, making it very easy to miss the diagnosis in an elderly adult. we have to always remember our gerontologic population, and certain considerations need to be taken even when discussing anemia with our gerontologic population. Hemoglobin does have a tendency to decline slightly as a normal function of aging, more so in men than in women. However, the normal decline is not enough to cause anemia symptoms all by itself. Your book points out that about a third of all anemia in the elderly is due to nutritional causes. Another third is due to renal insufficiency or chronic inflammation, both of which are often byproducts of aging, especially when concurrent illnesses such as hypertension and atherosclerosis are present. Target organ damage will be the final result of this third of anemias. So we can pinpoint causes for 2/3 of anemia cases in the elderly. The remaining third will have no identifiable cause. Signs and symptoms of anemia in the elderly do not differ greatly from anemia in other patients. However, they may segue into more serious manifestations such as confusion, ataxia, angina, and even heart failure. 3 basic categories of anemia: blood loss anemia, hemolytic anemia, or hypoproliferative anemia, which is defective production. The emphasis in level 2 will be on hypoproliferative anemias. These are the ones that result from lack of raw materials. These would be the nutritional anemias, such as iron deficiency, folic acid deficiency, or vitamin B12 deficiency. Let us start with iron deficiency anemia, or IDA. Adults usually have between 2 and 6 grams of iron, depending on the size of the person and the amount of hemoglobin in the cells. About 2/3 of this iron is contained in hemoglobin. The other 1/3 is stored in the bone marrow, spleen, liver, and muscle. With iron deficiency, the iron stores are depleted first, followed by the hemoglobin stores. Once the iron needed is no longer available, the red blood cell formed by the body becomes small, microcystic, and pale, hypochromic. Iron deficiency anemia is related to excessive iron loss caused either by bleeding, decreased dietary intake, or malabsorption. It is the most common type of anemia, especially in the elderly. The most common causes of IDA in men and the elderly is usually blood loss that comes from GI or GU system, such as hemorrhoids, GI bleeding, or cancer. This is a common anemia in women as well. Women lose about 15 milligrams monthly through menstruation. So it follows that menstruation is the most common cause of iron deficiency in women. In terms of actual numbers of patients, adult females with menstrual bleeding are the most common patients with iron deficiency anemia. This is also a common anemia for those who have limited means because they get few of the fresh foods that supply iron. It can also be the result of poor GI absorption of iron. Normally, iron excretion is less than 1 milligram per day through the urine, sweat, bile, feces, and from the cells of this squamated skin. IDA develops slowly in 3 phases. First, the body's iron stores are depleted. This leads to insufficient iron being transported into the marrow from the cell formation, for actual cell formation. Since there isn't enough iron to make new cells, the marrow produces small hemoglobin deficient cells that are released into circulation in very large numbers. Iron is needed on the hemoglobin for O2 to be able to attach. So these cells lack normal oxygen carrying capacity, which then in turn results in tissue hypoxia. We continue with assessment of IDA. Now, clinical manifestations usually develop gradually. The client often will not seek attention until the hemoglobin usually drops to either 7 or 8. Most of these symptoms are already very familiar to you. Cheilitis is an inflammation of the lips, especially cracking in the corners of the mouth. Pica is a craving to eat unusual or non-nutrient substances like cornstarch and clay, or even a constant craving to eat ice. That would fall under pica. And atropic glossitis is an inflammation of the tongue, which makes the tongue smooth and sore. And then you can see these in the slide in the pictures that are provided. So continuing with diagnostic studies for IDA, as we previously mentioned, iron deficiency anemia is considered a microcystic hypochromic anemia. That just means that the erythrocytes produced by the bone marrow are small and pale. As a result, the H&H is then decreased. So overall, red blood cell counts will be also reduced. Reticulocyte count is a measurement of the immature red blood cells in circulation. It reflects bone marrow activity in producing red blood cells. Fewer cells are being produced, and more of them are immature. So the count is either decreased or normal. And then serum iron levels are usually low, and that's really no surprise there because, of course, it's iron deficiency anemia. Ferritin is the form in which iron is stored in the body, and since stores have been exhausted, the ferritin level will also be down. Total iron binding capacity is the measure of the amount of iron that can be carried. So the other exam or diagnostic study for IDA is stool for occult blood, and it is where we test because of GI losses are so common cause of IDA. And if anemia is serious or reoccurring, usually an endoscopy and a colonoscopy is done to try and find a source of the blood loss. So we've gotten to the management of IDA. So it stands to reason that to treat iron deficiency anemia, we must administer iron. Always administer oral iron with orange juice or vitamin C. It will help to increase the absorption of iron in the body. Parenteral iron must always be given by deep IM injection via the Z-Track method. And I know that we discussed this during our pharmacology class. Use a separate needle for withdrawing and injecting, and add a 0.5 cc or ml airlock to prevent leaking of the iron along the needle track. The rest is pretty much common sense. This is a tired client with low energy. Interventions are aimed at conservation of energy and promoting rest. Energy-saving techniques are a good idea, such as use of shower chair or sitting to perform tasks. Provide a quiet environment to promote rest and sleep. Allow as much independence as possible, but be alert for the need to assist with activities, especially such as ambulation. Monitor for dizziness and suggest the client change position slowly. Encourage or assist with good oral hygiene before and after meals with a soft toothbrush, because gums will tend to be very fragile. Encourage at least 2,500 to 3,000 mL of fluid intake daily. Stool softeners and laxatives are as needed because iron is constipating to the body. Let them know that stools will be dark green or tarry when taking iron. And we need to monitor the H&H and red blood cell counts to be able to see how well management is going with the parenteral or oral iron. So we get to client education. Teach the client to maintain adequate nutrition. The elderly and those that are financially challenged may need referrals to agencies such as Meals on Wheels or WIC. Make sure that the client knows that antacids will block the absorption and should not be taken with iron. Oral liquid iron preparations will stain the teeth, so clients need to be aware that they need to use a straw and rinse their mouths well after any administration of oral iron, a liquid form. Teach the client to take iron on an empty stomach, if possible, because it is not absorbed well when taken with food. Tell them to take it with orange juice or some other drink high in vitamin C, because vitamin C does enhance absorption of iron. Make sure they know that iron may give them black stools. Tell them to report any persistent GI upset, as it may be caused by the iron supplements, and the supplements can then be changed to lessen the stomach upset. They may need a stool softener or a bulk laxative, and they should increase the fluid intake to keep their bowels regular. In the worst case scenario, if anemia is very severe, a transfusion may be necessary and the patient will be given packed red blood cells. Tell them which foods are high in iron. And again, we all know that what are some of those high iron foods, and those would be liver, other red meats, egg yolks, beans, dark green leafy vegetables, raisins, or molasses. An adequate diet supplies anywhere between 10 to 15 milligrams of iron per day, but only 5 to 10% of dietary iron that's consumed is actually absorbed. This amount is adequate for men and postmenopausal women. However, but not for women who are still menstruating. They may need supplementation with oral iron supplements. So now that we've discussed IDA, our second important anemia to know for this lecture is your folic acid deficiency anemia. And this naturally is the result of a lack of folic acid. Folic acid is a vitamin that is absolutely necessary for red blood cell synthesis. Production of red blood cells depends on adequate DNA synthesis in the precursor cells so that cell division and growth into functional red blood cells can occur. All cell division requires adequate amounts of folic acid in order to make DNA. One function of vitamin B12 is to activate the enzymes that move folic acid to the cell where DNA synthesis can occur. Vitamin B12 deficiencies causes anemia by inhibiting folic acid transport and reducing DNA synthesis in precursor cells. The precursor cells then undergo improper DNA synthesis and end up increasing in size. These large size cells are referred to as megaloplastic. They are also very immature. Due to their immaturity and large size, they have a tendency to become sequestered in the bone marrow instead of being released into peripheral circulation. And if they do get released, they are subject to a high rate of hemolysis because they have such a fragile cell membrane. Now, does anyone know where you normally get folic acid from? And you'd be surprised that it comes from green leafy vegetables, liver, fruits, and cereals. The client that has folic acid deficiency will be the client who is chronically undernourished. If you had to guess, what type of client would you assume are at high risk for folic acid deficiency? And you'd probably be right if you would say the elderly and the poor, but also pregnant clients because of the increased need of their blood circulation because they're producing a baby, but especially your alcoholics and drug abusers. The pathophysiology for this is the same as for iron deficiency anemia. The missing folic acid levels cause a drop in the red blood cell production, which leads to decreased oxygen carrying capacity. Folic acid deficiency anemia will cause the same general anemia manifestations we have already discussed, with no new wrinkles. We treat folic acid deficiency with improved diet and, of course, folic acid supplements. Now, we mentioned in the previous slide, vitamin B12 and its relationship with folic acid. Now, copolabine, which is also known as the generic name for vitamin B12 deficiency, is when the client is deficient in your actual vital vitamin of vitamin B12. It is a vital that we determine in this situation the cause of the vitamin B12 deficiency in order to be able to treat it effectively, because the treatments for vitamin B12 deficiency are very different in the two separate categories of vitamin B12 deficiencies. You have your nutritional causes or your dietary deficiencies, which are usually rarer because nutritional cases are only about 5% of your vitamin B12 deficiencies, or malabsorption due to bowel problems such as Crohn's disease, which is an ulcerative bowel problem, and malabsorption cases, which make up another 5%. Most cases of your B12 deficiencies are going to be due to pernicious anemia, which is a very specialized case of malabsorption. Now, pernicious anemia always develops after a total gastrectomy, which is removal of the stomach. About 15% of clients will develop it if only part of the stomach is removed. This is a very serious anemia because a lack of B12 alters the structures and function of the peripheral nerves, spinal cord, and brain. It also impairs cell division and maturation, especially in the red blood cells. Pernicious anemia happens when the body is unable to absorb B12. And the reason being that it can't absorb it is because it's lacking the intrinsic factor, which is a substance that is secreted by the gastric mucosa. It is believed that it may be an autoimmune disorder that affects the parietal cells of the stomach, which secrete intrinsic factor in that gastric mucosa. So when we're doing assessment for pernicious anemia, these clients have symptoms that are similar to other anemias, including that smooth, shiny tongue that comes from atrophy of the lingual papillae. But in addition to those symptoms, the client may have neurological manifestations, such as sensory disturbances and motor disturbances. The patient may have weakness, paresthesias of the feet and hand, reduced vibratory and position senses, muscle weakness, gait disturbances, and impairment of thought processes. Pernicious anemia can cause mental manifestations ranging from confusion all the way to dementia. And since this is very slow onset, and because it has a very slow onset, the symptoms can actually take months to actually develop. Now, the diagnostic test that would be used in order to diagnose pernicious anemia, because this is a macrocytic anemia, which means that under a microscope, the red blood cells will look very big and have abnormal shapes. Unfortunately, the cell membrane is puny. So these cells are very fragile and easily destroyed. We look at copalamin and folate levels. In these clients, we can also do a gastric secretion analysis. But perhaps more importantly, the clients have an increased risk for gastric cancer due to the alteration of gastric secretions. So a gastroscopy and biopsy of the gastric mucosa may also be done. The healthcare provider can also order a Schilling test. For that test, the patient is given radioactive copalamin, and then we just end up measuring how much of it is excreted in the urine. If the patient can't absorb vitamin B12, then only a small amount of the radioactive copalamin is going to be excreted in the urine. We can do this another way by giving them parenteral doses of intrinsic factor. They can If they can suddenly absorb copalamin when they're given intrinsic factor, well, then the diagnosis for pernicious anemia is made. And then lastly, we want to cover the management for pernicious anemia. So if it turns out that the client does not have pernicious anemia, but has vitamin B12 anemia, then the deficiency is caused basically by the lack of intake. This is vitamin B12 is very common in vitamin B12 anemia, is very common in vegetarians. So we have fortified soy milk, which can be added to their diet, and or oral supplements, since those clients retain the ability to absorb the vitamin. So remember that if it's just plain old vitamin B12 anemia, then they just basically need the supplement, and taking either oral supplements or foods that have been fortified in vitamin B12 will be enough to treat the anemia. If it proves that, if the test proves that now the deficiency is caused by a gastric malabsorption due to the lack of intrinsic factor, then the client will have to have lifelong replacement therapy. And unfortunately for these clients, the only choice is often IM injections. Parenteral B12 is given usually 1,000 micrograms IM times 14 days. Then again, then weekly until the hematocrit is normal. Once the client achieves normal hematocrit, they can then move to once a month for the rest of their lives, which is basic standard treatment for pernicious anemia. There is an intranasal form available as a nasal spray that's called Nasacobal. But and this is nice because the client can give this to themselves at home and administer it weekly. However, they still have to undergo the initial injection therapy with B12 until they're normalized, and then they can maintain with Nasacobal or Colomist, which are the nasal form. These nasal sprays are only approved for pernicious anemia clients, and they really have pernicious anemia clients that have no nervous system involvement yet. If they already have nerve involvement, they're not going to be suitable candidates for the nasal spray, and they have to have the monthly injections. The client needs to understand that they will need to be treated with B12 for life. And this condition can actually be fatal if treatment isn't continued for the lifespan of the patient. Assess the client carefully for paresthesias. Remember, nerve damage can be stopped by treating pernicious anemia, but damage that has already occurred may not be reversible. So interventions related to preventing the nerve injury is what should be incorporated for these patients. I hope you enjoyed this lecture, and you can contact us if you have any questions. Thank you.